Welcome back to Roadmap to Residency. Today we are attacking skin lesions and skin cancer on Step 3. We are not going to reteach dermatology. Instead, we will show you how the question stems are built, what words the test writers plant in the vignette, and how to move from the stem to the right answer quickly. You will see high-yield stems and full practice questions, with the reasoning for every right answer and every distractor. Pair this with your question bank. Let us begin. Here is our plan. First, benign lesion identification, because Step 3 loves to hand you a scary-sounding finding that is harmless, and the answer is reassurance. Second, melanoma screening using the 5 warning letters. Third, biopsy technique, one of the most commonly missed points on the exam. Fourth, referral criteria, so you know when the answer is refer and when it is treat it yourself. Throughout, we emphasize the words in the stem that give the answer away. For content, work the skin and subcutaneous tissue section of your question bank and the dermatology chapter of your review book. Strategy 1 is recognizing the benign lesion stem. A large share of skin questions test whether you can leave something alone, and the writers use a consistent vocabulary. Stuck on, waxy, or greasy in an older adult points to seborrheic keratosis. Symmetric, uniform, sharply bordered, and unchanged for years points to a benign mole. Soft, compressible, and mobile points to a lipoma. A firm nodule on the leg that dimples when pinched points to a dermatofibroma. When you see that vocabulary, stop hunting for cancer and hunt for the choice that says reassure and observe. The tempting wrong answers offer biopsy, excision, or referral. They feel thorough, but a procedure on an obviously benign lesion is scored wrong. Escalate only when the stem plants a change, a new symptom, bleeding, or an appearance called irregular. Strategy 2 is melanoma screening as it appears inside a stem. 5 features. Asymmetry, where the halves would not match. Border irregularity, described as notched, scalloped, or poorly defined. Color variation, multiple shades within one lesion. Diameter over 6 mm, often compared to a pencil eraser. And evolution, meaning it changed. Here is the strategy. Do not count features chasing a threshold. Hunt for the word change. Evolution is the highest yield feature in the vignette. If a mole has grown, darkened, begun to bleed or itch, that lesion is getting sampled regardless of what else is in the stem. Conversely, when the author says unchanged for 20 years and uniform in color, you are being handed reassurance. Read the change words first, then check the other 4 to confirm. Strategy 3 is biopsy technique, and this is where students hemorrhage points. When the stem describes a pigmented lesion that worries you, the answer is a narrow excisional biopsy that removes the entire lesion, full thickness, down through the fat. Depth of invasion determines the stage, the surgical margin, and whether the patient needs a lymph node evaluation. If the pathologist cannot see the deepest point, the pathologist cannot stage it. Now the trap. Almost every melanoma question offers a shave biopsy. A shave slices horizontally, transects the tumor, and destroys the depth information. Cross it off on reflex. 2 more distractors. A punch biopsy is excellent for a rash or inflammatory condition, but not your first choice for a small suspicious mole. And a wide local excision is treatment, not diagnosis. Choosing it before a tissue diagnosis is the overkill answer, and this exam punishes doing too much as hard as doing too little. Our first practice question. A 48-year-old man comes to clinic because a mole on his upper back has changed. It has grown over 4 months and now has a darker area within it. Examination shows a 7 mm pigmented lesion with an irregular, notched border and 2 shades of brown. The rest of the skin exam is normal. What is the most appropriate next step in management? A. Shave biopsy. B. Narrow excisional biopsy of the full lesion. C. Wide local excision with 2 cm margins. D. Photograph and reassess in 6 months. The question asks for the next step, so the exam wants an action now and the diagnostic action before the therapeutic one. It grew. It darkened. The border is notched. 2 colors. 7 mm. Think about which choice preserves the information you need. First, spot the pattern. Asymmetric growth, a notched border, 2 shades of brown, and 7 mm above the threshold. And the loudest clue, it changed over 4 months, 4 of 5 warning features with evolution front and center. This is suspicious until tissue says otherwise. Second, apply the rule. A suspicious pigmented lesion needs a full thickness sample capturing the entire base so the pathologist can measure depth, which determines stage, margin, and whether nodes are evaluated. The answer is B, the narrow excisional biopsy. Third, eliminate. Choice A, the shave, transects the tumor and loses the depth measurement forever. It is the most commonly chosen wrong answer on melanoma questions. Choice C is treatment, not diagnosis. You cannot pick a margin without knowing depth. That is the overkill trap. Choice D would be reasonable for a stable lesion, but the author told you it grew and darkened. Watching a changing lesion is wrong and dangerous. The answer is B. Our second practice question tests the other half of the skill set, knowing when to do nothing. A 68-year-old woman is worried about a spot on her chest. Examination shows a 5 mm tan brown plaque with a rough, waxy surface that appears stuck onto the skin. The borders are sharp and the colour is uniform. She has several similar lesions on her back, with no change, no bleeding, and no itching. What is the most appropriate next step? A. Excisional biopsy. B. Urgent referral to dermatology for a full body survey. C. Reassurance and routine skin surveillance. D. Shave biopsy to rule out melanoma. Read the descriptors. Waxy, stuck on, sharp borders, uniform colour, multiple similar lesions, unchanged. Everyone is a deliberate signal. Ask what the author is telling you. First, scan for warning features and notice the author removes everyone. Uniform colour, so no colour variation. Sharp borders, so no border irregularity. 5 mm, so under the threshold. No change, no bleeding, no itching, so no evolution. When a writer negates each warning feature by name, that is not filler, that is the diagnosis. Add the waxy, stuck-on appearance in an older adult with several similar lesions, and you have a textbook Seborrheic keratosis. Benign. The answer is C, reassurance and routine skin surveillance. Now the distractors. Choice A, subjects a benign lesion to a procedure, produces a scar and yields nothing useful. Choice B is the overkill trap dressed as caution, and the word urgent should make you suspicious. Choice D is wrong twice, an unnecessary procedure and the wrong instrument for a pigmented lesion. The exam is testing whether you can hold your nerve. The answer is C. Strategy 4 is dermatology referral, a subtler judgment than students expect. Refer when the lesion sits on a cosmetically or functionally sensitive site, the face, ear, eyelid, lip, fingertip, or genitals, because removal there requires specialized technique. Refer when the lesion is very large. Refer when a biopsy already returned positive for melanoma, since that patient needs definitive excision and possibly nodes. Refer for an undiagnosed rash after reasonable evaluation. And refer the patient with many atypical moles who needs ongoing surveillance. Now the trap. The exam offers refer to dermatology on a question where the patient has a clearly changing lesion on the back that you could biopsy today. There, referral is wrong. It looks responsible, but it delays diagnosis of a potentially lethal cancer. Referral is also wrong when the lesion is obviously benign. Ask 2 questions. Can I safely get the tissue myself today? And does this patient need something a specialist can do that I cannot? Our third practice question puts referral to the test. A 72-year-old farmer has a lesion on the side of his nose, slowly enlarging over the past year, that bleeds when he shaves. Examination shows a 9 mm pearly translucent nodule with rolled edges, fine visible vessels, and a small central ulcer. He has extensive sun damage. What is the most appropriate next step? A. Referral to dermatology for biopsy and definitive management. B. Reassurance and observation for another year. C. Wide local excision with 2 cm margins in clinic today. D. A topical steroid cream and follow-up in 3 months. Notice the descriptors: pearly, translucent, rolled edges, surface vessels, central ulcer, slowly enlarging, bleeding, and notice the location, because this is where the referral rule does real work. First, read the descriptors: pearly, translucent, rolled edges, fine vessels, a central ulcer, slow growth over a year, bleeding, and a lifetime of sun exposure. That is a basal cell skin cancer, and every word was placed on purpose. Because this is malignant, choice B is wrong. You do not observe a growing, ulcerating, bleeding cancer. Choice D is worse, treating a skin cancer as a rash and buying the tumor 3 more months. Second, the key distinction is location. This lesion is on the nose, a cosmetically and functionally sensitive site where removal requires tissue-sparing technique. That is exactly when referral becomes correct rather than lazy. Compare it to the mole on the back, where you should biopsy yourself. Same principle, opposite conclusion, because the site changed. That leaves choice C, wrong twice. It removes tissue before a diagnosis, and a 2 centimeter margin is a melanoma margin, wildly excessive here. The answer is A. Here is the exam day pearl, a 2-move algorithm you can run in under 30 seconds. First move, hunt the descriptors before reading a single answer choice. Waxy, greasy, stuck on, sharp-bordered, unchanged means benign. Asymmetric, notched, multicolored, over 6 millimeters, and above all, changing means melanoma. Pearly, translucent, rolled edges, telangiectasias, and central ulceration in a sun-damaged patient means basal cell. Scaly and rough on the lip, ear, or hand points to squamous cell. Read the adjectives and the location, and the diagnosis is in your hands. Second move, ask 2 questions. Does this lesion need tissue? If no, choose reassurance and do not let fancier choices talk you out of it. If yes, can I get that tissue safely myself right now? On the trunk, arm, leg, or back, yes, choose the narrow excisional biopsy. On the face, ear, or eyelid, no, choose referral. 2 absolute rules on top. Never shave a pigmented lesion. Never widely excise before a tissue diagnosis. That wraps up skin lesions and skin cancer on step 3. The essentials. Recognize the benign lesion by its descriptors and have the confidence to reassure. Hunt for the word change in every pigmented lesion stem, because evolution outweighs every other feature. When a mole is suspicious, take the whole thing, full thickness, with a narrow excisional biopsy and never accept a shave. Refer when the site is sensitive or the melanoma is confirmed, and refuse to refer when you could get the tissue yourself today. For studying, drill the skin and subcutaneous tissue section of your question bank and the dermatology chapter of your review book, and read every explanation, including for questions you got right. If this video helped, please like and subscribe. Visit us at roadmaptoresidency.com, where our expert tutors and residency advisors can build you a personalized study plan. Good luck on your exam, and we will see you in the next one.